So this is about pathology of esophagus and stomach. Actually, I'm going to go very slow here because I'm not going to cover both esophagus and stomach in one stretch. So let us go a little bit slow here. Very important diseases and very common diseases you will encounter in clinical practice. So let us start with the learning outcomes for this lecture. Inshallah, after this lecture, you girls can list the causes as well as you can describe the morphology of certain diseases of esophagus, especially esophagitis, Barrett's esophagus, as well as you can differentiate between premalignant and malignant conditions of esophagus. This is our target. So you can able to list the cause of this condition and you can able to describe morphologically. Why morphological description is important, then only you can understand the clinical findings. Then only you can understand the clinical findings. See, a good doctor, whenever he hears the symptoms or whenever he see the sign, immediately he should, in his mind, he should able to visualize the pathology. So then he will become a best doctor, understand, best physician. If somebody cannot able to visualize the pathology, then he cannot able to do a proper investigation and to come to a final conclusion. Okay, so then only you can manage, you can plan the management for the patient. Okay, you have to plan the management not for the disease, you have to plan the management for the patient, understand. So keep in your mind, pathology is the science which make you to give evidence for the clinical findings, understand. This is very very important because nowadays we are living in a stage, in the period called evidence based medicine. Okay, you cannot treat any patient without having appropriate evidence. Evidence means investigation, findings of the investigation, keep that in your mind. So the next outcome is you can list the causes and explain the pathogenesis as well as the morphology of two very common condition in the stomach pathology, that is gastritis and peptic ulcer. Gastritis and peptic ulcer, and you can able to differentiate between the benign and malignant gastric tumors. Everything we give the difference on the basis of morphology and clinicopathological feature to come to a final conclusion, that is appropriate diagnosis, to arrive at appropriate diagnosis. Let us go into the one by one, let us go into the diseases. So first I am going to discuss, even though it is not mentioned in the outcome, this is very very important disease, that's why I should not miss this disease, that's why I am discussing it. It is called obstructive diseases of esophagus. Obstructive diseases of esophagus. What it causes is difficulty in swallowing. Difficulty in swallowing. These diseases will produce difficulty in swallowing. Okay. So most of the disease which I am mentioning, it comes in the early period of life. Early period of life. Because these are related to congenital disease. Related to congenital diseases. One is agenesis of esophagus, that is esophagus is absent. Esophagus is absent. Agenesis means formation of esophagus itself not happened. So it is very rare condition. It is very rare condition. Then atresia. Atresia means esophagus is a tube, right? Esophagus is a tubular organ. It's like a pipe. We call it a food pipe. So it's a tubular organ. Instead of to being as a tubule means it should have a hole, right? It should have a lumen. It should have a lumen. Instead of having the lumen, if there is lumen is absent, it is like a sheet. It is like a sheet. So that is called atresia. That is called atresia. So it is a thin non-canalized. It looks like a non-canalized means there is no lumen. There is no lumen. Thin non-canalized cord replaces a segment of the esophagus. Not complete. A small segment is replaced. For example, there is a esophagus. This middle of the esophagus, there is no canal. There is no lumen. So food cannot go, right? So that is one of the commonest condition. And location, usually it will be near to the tracheal bifurcation. Tracheal bifurcation. See, esophagus is there, then trachea is there, then trachea divides into bronchus, right? So just near to that area, this usually is seen. Okay. So sometimes this area, which is there is no lumen, which is like a sheet, okay, that also may have connection with the trachea. That also may have connection with the trachea. That may have two side opening. Esophagus and trachea, they can make like a opening. So that is called fistula. That is called fistula. Okay, this is very dangerous because what are the food they are taking, it can go into the lung. It can go into the lung. It will cause aspiration. It will cause aspiration pneumonia, all serious complications it will produce. All serious complications it produce. So this connection of the upper or lower esophageal pouches to a bronchus or the trachea is called fistula, and this abnormal connection can result in aspiration because it goes to the lung, and suffocation means that area becomes consolidated, then the oxygen will not carry. Then pneumonia, infection can come, and it leads to severe fluid and electrolyte imbalances because the food is not going into the stomach. Food is not going into the stomach. Okay, now coming to the, if you ask me in the four condition which is most commonest, I will say stenosis of esophagus. Okay, so stenosis means it is not complete closure. Okay, it becomes smaller. The lumen will the if you take the diameter of the esophagus, that will become narrow. So the narrowing generally happens due to fibrous thickening of submucosa, atrophy of muscularis propria because of epithelial damage. You understand? So you all know the layers of gastrointestinal tract. Yeah. So you have a mucosa. Okay. No, you have to go a little bit more here. Okay. So mucosa, lamina propria, then muscularis propria, then submucosa, then muscularis coat, then serosa. Okay. So in the mucosa, we have three things. One is lining epithelium and lamina propria and muscularis propria. Okay, this is very important because you see a gland above the muscularis propria, it is mucosal gland. If you see a gland below the muscularis propria, it is submucosal gland. So keep that in your mind. In some part of the gastrointestinal tract, muscularis propria is absent. That I will discuss when I am coming. Okay. So now generally you have this layer. Likewise, esophagus. You all know the upper 1/3 of the esophagus, middle 1/3 and lower 1/3. The layer little bit shows variation, especially in the muscularis layer. What happens? So you see more skeletal muscle in the upper 1/3, in the middle 1/3 mixture of skeletal muscle and smooth muscle. Anatomy they didn't take this. No. So there is a mixture of esophagus is not over. We didn't take esophagus. Okay. So in the middle of esophagus there will be mixture of skeletal and smooth muscle. In the lower 1/3 you will be seeing only smooth muscle. Okay. So this is very, very important. So initially 1/3 of the esophagus is mainly controlled by the skeletal muscle. It is controlled by the skeletal muscle because the peristalsis is, you all know peristalsis. So peristalsis is how the food goes into the stomach. Okay, it goes like a downward wave. Anything the wave comes above, it is anti-peristaltic wave. That is vomiting. Okay, anti-peristaltic wave. So they will be talking in physiology about peristalsis in detail as well as in anatomy. Okay, now why I am telling this is, if the mucosa, that is the lining epithelium, is damaged, okay, then automatically the submucosa will go for fibrosis. The submucosa, because it gets damaged because of inflammation. Then in chronic inflammation they will go for fibrosis. Then when they go for fibrosis, fibrosis, what will happen? Collagen will constrict, right? So automatically the lumen will be narrowed. So stenosis most often is due to inflammation and scarring. chronic inflammation, will go for scar formation, and it is commonly seen in gastroesophageal reflux disease, that is chronic gastroesophageal reflux disease, or if you give any radiation therapy, or caustic injury means any direct injury. So stenosis is associated with dysphagia. It is associated with difficulty in swallowing. So initially it will be difficulty to swallow the solid foods. Initially it will be difficult to swallow the solid foods. When it becomes severe and severe, it goes for difficulty to swallow even the fluids. When somebody is coming to you that I cannot even swallow the fluid, or I am getting too much of pain when I am swallowing the fluid, if the pain plus swallowing, during the swallowing if they have a pain, it is called odinophagia. Only swallowing difficulty is there, it is called dysphagia. Okay, so the severity of the dysphagia, how we understand, if they have a difficulty in swallowing the fluids. So this is how the stenosis comes as a clinical presentation. Now so far we discussed about mechanical obstruction. Okay, now we are going to discuss about functional obstruction of esophagus. So any motility is affected. Okay, so because this is, I will show you the peristalsis. I have one picture. That time you can understand much better. So now dysmotility means the movement of esophagus is going for dysfunctional. So that is affected, then automatically this is called functional obstruction. Okay, so it can be due to discoordination between the muscles. So especially happens in the muscularis layer. So it is leads to spasm of muscularis. So we call this condition as achalasia. Okay, achalasia. So it has three things. One is incomplete lower esophageal sphincter relaxation. See, this is esophagus. Then we have stomach. Here they have a sphincter. This is called lower esophageal sphincter. So when the food comes, they should relax. Okay, so then only the food can go into the stomach. So if they are constricting or they are not relaxing, so automatically why? Because the muscle surrounding the sphincter is not relaxing. So automatically they cannot send the food down. So that will leads to dysphagia, and clinically it is called achalasia. So three things they have. One is incomplete LES, lower esophageal sphincter relaxation, and another one is increased lower esophageal tone. In tone means, for example, I am holding this pen very tight. Okay, so these muscles are contracting. Understand? So if the muscle tone is good, okay, I cannot take this pen. Understand? Muscle is contracting. If muscle tone is weak, I can take this pen out. Understand? So that's why if the tone is affected, then automatically if the tone is very strong, okay, then they cannot relax. So they cannot freely, the food can go into the stomach. And another one is there is no movement. Aperistalysis. There is no peristalsis. These are the three reasons seen in the three characteristic features seen in the achalasia. So now we classify the achalasia into primary and secondary. So secondary is very important because this is due to infections. Primary is normally very rare. So it is usually due to nerve problems. Okay, so if there is failure of inhibitory neurons, okay, we don't know why it happens. Okay, we assume this is happening. Okay, so if there is any neuronal dysfunction, okay, or the vagus nerve is affected, then you have this kind of problems. So sometimes the person is having some tumor in the inside the cranium, okay, intracranial tumors. So inshallah in the CNS I will be discussing more if I am taking. So there are certain tumors which destroys the vagal nucleus inside. So then automatically all the vagal nerve innervated organs go for affected. It will be affected. So these are the things you should keep in your mind. Or for example, if there is anything happening in the areas of this spinal cord, then the dorsal nucleus of the vagus can be affected. Okay. So if you have a very good basics of anatomy and physiology, you can understand these neural lesions very clearly. Okay. So any area in the brain where the vagus nucleus is affected and the spinal cord it is affected, then automatically the esophagus cannot have the good peristalsis. Good peristalsis. Now coming to the secondary achalasia, the most important one is Chagas disease. It is called Chagas disease, very common disease in America. So it is caused by a parasite called Trypanosoma cruzi. Trypanosoma cruzi. So this destroy the myenteric plexus. There is a neuronal plexus in the wall of the esophagus. In the wall of the esophagus that is destroyed, that leads to failure of lower esophageal sphincter relaxation, and esophagus goes for dilatation. Esophagus goes for dilatation. So this is the most commonest one, that is comes under secondary achalasia. Secondary achalasia can happen in other diseases, in diabetic or infiltration disorders like malignancy, amyloidosis, sarcoidosis. So dorsal motor nuclei can be affected by a polio or any surgery you are doing in this area. So that can also affect. So why I am giving these examples is, these are the examples they give you case scenarios. Okay, so these are the examples, very commonest asked case scenarios only I am giving as an example. Okay, why we ask these scenarios? Because this is the one commonest you will encounter when you go to residency. That's why we test you whether you know it or not. So once again I am telling, the secondary causes of achalasia is very common. So the first disease you should remember is Chagas disease, because it destroys the myenteric plexus. This destroys the myenteric plexus, and that leads to failure of lower esophageal sphincter relaxation. So lower esophageal sphincter becomes very constrictive, so they cannot relax. If they are very constrictive, what happens? Next step, esophagus will dilate. Esophagus will dilate. So that's the two things happens. And remember, in Chagas disease, it can affect other parts of the intestine, other part of the gastrointestinal tract. So even in the ureter can be affected. Ureter can be affected. Okay, so which means they have a difficulty in micturition, they have a difficulty in urination, so they have a difficulty in swallowing, difficulty in urination. So this is how you have to identify from the clinical findings. Understand? So immediately you should think of Chagas disease because of the Trypanosoma cruzi. So other diseases also mimic. For example, diabetic can mimic like a Chagas disease, very commonly diabetic. But age is very important. We know his blood glucose level will be elevated. All other findings will be there to come to a conclusion. Now coming to the lacerations and rupture of esophagus, very important. Okay, it is related to the peristaltic and antiperistaltic wave. See, normal peristalsis happens like this. Okay, so there will be a constriction to send the food inside, then they relax. Lower part has to go for relaxation. For example, if the food is going inside the pipe, so first they have to constrict to send the food inside, then the lower part has to receive the food. So the lower part has to go for relaxation. So constriction and relaxation happens alternatively. That creates a wave. That is called peristaltic wave. So the wave will be like, for example, then they constrict, then they relax, constrict, relax. So it will be like a wave of motion happens in the intestinal tract, so gastrointestinal tract. So there are anti-peristaltic wave which goes from downward to upward. Okay, this anti-peristaltic wave is coming if this area is not relaxing. Okay, then for example, the lower esophageal sphincter is constricted, Now from the stomach antiperistaltic wave is formed. It is not relaxing. Okay, so then this will go for damage. This will go for damage. Understand? Because they are forcefully sending the food out. If it is not relaxing, that area will be forcefully opened. That area will be forcefully opened. That will produce laceration. That will produce laceration, and sometimes it leads to rupture. Sometimes it may leads to rupture. So there are two conditions I am going to discuss. It is called a syndrome, very commonly encountered. Okay, the most commonly encountered is Mallory-Weiss syndrome. It is called Mallory-Weiss syndrome, and if it goes for rupture, it is called Boyer-Haave syndrome. Boyer-Haave syndrome. See, just I am giving the normal here. The reflex relaxation of the gastroesophageal musculature precedes the antiperistaltic contractile wave associated with vomiting. Understand what I am trying to tell here is, see, when there is a antiperistaltic wave, before the antiperistaltic wave formation, the sphincter will relax, because otherwise this area will go for rupture. So they know it, so they are relaxing before starting of the antiperistaltic wave. So then antiperistaltic wave is formed, the food will come out. So now the content, not food, the content of the gastric content will come out. Okay, so now this relaxation is thought to fail. It is failed during prolonged vomiting. This relaxation will fail during prolonged vomiting. So that results in reflecting gastric content overwhelm, means damaging the gastric inlet and causing esophageal wall to stretch and tear. Okay, this is the pathogenesis. And why it is happening? Most commonest cause is chronic alcoholism. In alcoholic patient, we commonly see these tears. So clinically they come with heartburn. They say that some burning sensation, and that too after drinking alcohol and these things. And we ask, did you have a vomiting last night? Like that we'll ask. So usually they have a complaint of vomiting after drinking. So it is related to the Mallory-Weiss syndrome. If it is ruptures, it is called Boyer-Haave syndrome. It is very clinical emergency if it ruptures. Okay, so this is the two endoscopy finding. You can see a small lacerations here. Okay, small lacerations, and it will be longitudinal. And here you are seeing the complete rupture. You are seeing the complete rupture in endoscopy. So this is transmural, that is complete wall of the, transmural means all the wall, mural means wall, trans means complete wall of the esophagus goes for rupture. And here you will be seeing longitudinal tears. So now coming to the irritations and infections of esophagus, let us finish the first irritation. Irritations means mainly due to some chemical substances, that is called chemical esophagitis. The stratified squamous mucosa of the esophagus is damaged by irritants, some drugs, pills means drugs, radiation therapy, chemotherapy, and another condition called graft versus host disease. You know GVHD, graft versus host disease. In immunology they took the POD. See, graft versus host disease means you are taking a bone graft from a person and you are putting in a recipient. You are taking a bone marrow. Okay, we take a bone marrow from a donor and we are putting in a person who is having blood cancer, for example. Okay, so for what we do, if a blood cancer patient going for bone marrow transplantation, so first we will kill that person's bone marrow by giving powerful radiation. That person who is going to receive new bone marrow, that person will take him to a condition called aneutropenia, zero neutrophil condition. Understand? So that's why bone marrow transplant ward, very few people are allowed inside. That is called aneutropenic ward. Okay, aneutropenic ward means the patient doesn't have any neutrophil like that state, which means he will be very prone for infection. So then we make a patient like that. Then we give a new transplant, new bone marrow from a donor. So when you give a new bone marrow, Now that bone marrow will produce blood cells, okay, that will go and attack the donor tissue, so graft means new bone marrow versus host, the host go for reaction, okay. So that is called graft versus host disease. It is a big challenge for the bone marrow transplantation. This disease is big challenge for the bone marrow transplantation. So this patient will produce lymphocyte and antibodies that will attack the esophagus, so these all the things can produce inflammation to the esophagus. The inflammation to the esophagus then can damage the mucosa. So I am giving the causes: ingestion of acid, alkali, hot fluids, alcohol, heavy smoking, radiation therapy and chemotherapy. Sometimes nowadays the major problem is coming due to drugs. So this problem was not there when I am doing medicine, okay. Frankly, it is like hardly 18-20 years back. So now the problem is that we give lot of drugs. Some of the drugs now we found it is getting attached to the mucosa, okay, that creating reaction, that is called pill-induced esophagitis. Okay, now morphology. In the pill-induced esophagitis, you will be seeing ulcerations and you see lot of neutrophils. You feel lot of neutrophils. What all you are seeing in between the cells is neutrophils. These are all neutrophils. And if it is due to radiation, the characteristic change is blood vessel thickening. Okay. Now I should ask some question here. Why I am teaching this to undergraduate? Why I am teaching in irradiation, means radiation therapy, the blood vessel goes for thickening. What is the reason for me to teach? Because this is looks like very for a residence level, okay. Why I am particularly taking this point and telling to you? For example, there is a cancer patient, okay. He is going to, for example, to Medina from here. He got some accident and he has been in radiation therapy, okay. Usually when becomes diseased, we becomes more spiritual, okay. So that's why I am giving this example, because real time example, this is all the examples which we encounter in clinics. So he went to Medina, somehow he got an accident, okay, somehow, or he got a sick and he came to the hospital. So that time the treating resident or intern or any medical people in the ward, they should be aware that radiated patient will have thickening of the blood vessel. So if he comes with injury, you have to not, when you want to stop the bleeding, if you just pack it, it will not stop the bleeding. You have to tie the blood vessel. You have to identify which blood vessel is ruptured and you have to do a tying, okay, because if you keep anything other than that, it will not close, because the blood vessel wall is thick and it will not react like a normal blood vessel. It will not react like a normal blood vessel. What are the points we are telling in pathology? We give only points which is relevant to clinicals, okay. So keep that in your mind. That is the reason we are telling. So wherever we use the radiation, for example, I am not giving radiation. For example, why the esophagus is affected, in which radiation it could be affected? The person is coming with lung cancer. When the person comes with lung cancer, I give a radiation here, okay. So there is a radiation, type of radiation called cyber knife treatment. It is called, recently it is evolved, like last 5 years. So what happens is, I fix a tumor in the lung, that machine also moves along with the lung, okay. So it hits the tumor only, not other area. It hits the tumor only, not other areas. So previously, this is very costly. Still now it is very costly. Understand, very costly. I think maybe I don't know whether in Saudi which hospital has this, but it is very costly treatment. In Asia alone, only 3 hospitals has. Okay, it is called cyber knife. So it is the best treatment. Very cost effective. It's very costly. Okay. Otherwise, what we give is, we fix the area. and the whole area we send the radiation. Okay, so in that area the lung is we are giving, the esophagus will be affected. So when esophagus is affected and the patient cannot have proper constriction of blood vessels, so automatically if any bleeding happens, the blood vessel will not constrict, the blood vessel will not constrict. So it happens in all the areas which you give radiation, it happens in all the areas which you give radiation. Okay, now coming to the infectious esophagitis. Again, the stratified squamous cells are infected by the virus and fungus, especially in immunosuppressive state. Especially in immunosuppressive state. So the viral infection, two viruses are very important: herpes simplex virus and cytomegalovirus. Cytomegalovirus, fungus, Candida albicans, mucormycosis, aspergillosis. This mucormycosis comes in diabetic patient. So then sometimes the squamous cells will fall because the squamous cells are attached together. So this attachment are weak, then the squamous cell will fall. So this attachment are all made by proteins. For example, cadherin. So some antibodies are produced against that cadherin that will destroy that cadherin, then they will fall. So that is called desquamative disease. Desquamative disease. So in those diseases you will be seeing this kind of infections. So now coming to the morphology, they produce very large ulcers. Two types of ulcers are seen. We can classify which infection it is. So if it is punched out ulcer, like some, just you are making like some area is removed, like punched out, or it is swallow ulcer. Shallow ulcer means it's like this, superficial. Okay, and punched out means the bigger area is taken out. The bigger area is taken out. If it is punched out ulcer, it is herpes simplex. It is herpes simplex. If it is shallow ulcer, it is cytomegalovirus. It may be of cytomegalovirus. And remember, in herpes simplex, the inclusion will be seen in the nucleus. Inclusion will be seen in the nucleus. Whereas in nucleus of the epithelium, nucleus of the squamous cells, nucleus of the epithelium. But in cytomegalovirus, the inclusion will be seen in nucleus and cytoplasm of endothelium, that is blood vessel of endothelium. So this is very, very important finding. So if I see this finding, I can say whether it is a herpes or whether it is a cytomegalovirus, because both have different treatment. So now coming to the reflex diseases of esophagus. You all know this disease, we discussed somewhat in the POD. Okay, gastroesophageal reflex disease. Okay, so now stratified squamous epithelium of esophagus is resistant to abrasion. Any food particle comes, it is resistant, they cannot damage, but is sensitive to acid. So the submucosal glands of proximal and distal esophagus protect by secreting mucin and bicarbonate. So now you have a esophagus and stomach. Now the proximal esophagus and the distal esophagus. This is distal, this is proximal. Proximal and distal esophagus secrete what? Mucin and bicarbonate. So any acid comes from the stomach, it will be solved. So they cannot damage it. So if there is constant lower esophageal sphincter tone, prevents reflex of acid gastric content. If the sphincter tone is good, the gastric cannot come up. So the reflex of gastric content into lower esophagus is the most commonest cause of esophagitis. That is, the stomach content entering the esophagus is the most commonest cause for esophagitis. So clinically we give a name called gastroesophageal reflex disease. So what are the causes? First you should know what are things can affect the LES tone. So alcohol, tobacco, hiatus hernia, any depressant drugs you take for the depression treatment. So any CNS depressant. So these are the things will produce decrease in lower esophageal sphincter tone. Anything increased abdominal pressure, for example pregnancy, that will create pressure in the abdomen, so the stomach is constricted, So it can the gastric content come into the esophagus. Likewise, obesity, delayed gastric emptying and increased gastric volume. Some person takes too much of food or the delay in the gastric emptying. This all causes increased abdominal pressure. In many of the cases, we can't know what cause it is. Okay. Sometimes we say you are obese, so you reduce your weight, it will come down. So likewise, we give there is no any cause, but they keep on having this disease. They will keep on having this disease. Okay. Yeah, hiatus hernia, inshallah, I will discuss. The hiatus hernia means nothing but, the esophagus has a opening in the diaphragm. So esophagus enters into the abdominal cavity. Esophagus enters into the abdominal cavity. This is called diaphragmatic crura. Diaphragmatic crura. Okay. So if the diaphragmatic crura is weak, some part of the stomach enters into the chest. Some part of the stomach enters into the chest. That is herniate into the chest. Herniate into the chest. That is called hiatus hernia. That is called hiatus hernia. So some part of the gastric area in the chest. So now it is like in the esophagus. Easily it can enter into the esophagus. Understand? So that will produce serious gastroesophageal reflux disease. Okay. Now coming to the normal esophagus. This is the normal squamous epithelium. You are seeing some glands and you are seeing the muscle coat. You are seeing the muscle coat. Okay. Now in reflex and eosinophilic esophagitis, you will be seeing basal cell is increased. Basal cell is increased. So first feature is basal cell hyperplasia. Basal cell hyperplasia, and you will be seeing one or two eosinophils. One or two eosinophils. That is reflex esophagitis. That is reflex esophagitis. If you see more eosinophils, see here lot of pink colored dots. If you see more eosinophils, it is eosinophilic esophagitis. It is eosinophilic esophagitis because in eosinophilic esophagitis, it is not due to reflex. It is not due to reflex. It is due to allergic condition. It is due to allergic condition. Okay, but both will have same clinical feature, heartburn. Sometimes they will have dysphagia. The most important clinical finding is it can mimic like a angina. It can mimic like a angina. Understand? That's why if the person is around 50-55 and he is a known case of hypertensive, is a known case of diabetic, is a known case of dyslipidemia, and if he is coming with heartburn or sometimes it looks like a angina kind of symptom, don't take it lightly. Do the ECG, confirm everything, then you can come to a conclusion. It may be due to his overeating last night. You understand? Don't immediately ask he went to Albeck at 2 o'clock, so he got this heartburn. Okay? So many of the patients died because of not approach to the proper approach to the patient on appropriate time. Understand? So whenever, that's what clinical scenario is very important. It can mimic like a chest pain. It can mimic like a chest pain. And the problem here is they can produce ulcers, strictures, and hemoptymesis means blood will come out, and melena means the blood stool, and it can lead to a condition, metaplastic condition called Barrett esophagus. A metaplastic condition called Barrett esophagus. So Barrett esophagus is a complication of chronic gastroesophageal reflux disease. Chronic gastroesophageal reflux disease. What is that? It will have a intestinal metaplasia. It will have a intestinal metaplasia within the squamous mucosa. Within the squamous mucosa. Why it is very important? If the person is having Barrett esophagus, he has an increased risk of getting adenocarcinoma. He has increased risk of getting adenocarcinoma. Morphologically, this is the normal appearance of esophagus. Pale color. If it becomes Barrett esophagus, it will become like a reddish velvety appearance. Reddish velvety appearance. So a tongues or patch of red velvety mucosa extending upward from gastric mucosa. Extending upward from gastric mucosa. The normal squamous mucosa appear pale and gastric mucosa appear light brown. Light. See, this is gastric mucosa. It is appearing light brown. And the transition between esophageal squamous mucosa and metaplastic mucosa is they contain goblet cells. They contain goblet cells. So histologically, gastric or intestinal metaplasia is a diagnosis of Barrett esophagus. But remember, histologically, I have to see goblet cell. I have to see goblet cell. That is very, very important. So must feature to diagnose is goblet cell. Must feature to diagnose is goblet cell. It
is not present.
Yeah, you have to know first of all histology, my dear. So it is a complete from starting point of esophagus till the end of esophagus. It is lined by non-keratinizing stratified squamous epithelium. Okay, you will never see any kind of glandular epithelium there. You will never see any kind of glandular epithelium there. Okay, so if you see a glandular epithelium, I will be seeing whether I see a goblet cell or not. If I see a goblet cell, then it is what it is Barrett's esophagus. Okay, so I am giving a description of goblet cell, and it is not much important. And intestinal metaplasia defined if you see a goblet cell, it is confirmed if you see a goblet cell. So then I see in the Barrett's esophagus dysplasia, because dysplasia is disordered proliferation. It may be high or low grade. Even it can have a intramucosal carcinoma, which means there is a cancer cells spread at the mucosal layer. It will keep on spreading at the mucosal layer. So we have to remove only the mucosa. Very, very complicated treatment that is. Okay. So now the cancer cells may be seen in the lamina propria. It will be seen in the lamina propria. Clinical feature is you have to do endoscopy and biopsy to diagnose this condition. You have to do endoscopy and biopsy to diagnose this condition. And remember, whenever you take a biopsy, see the report what we are sending. We use 3 words: simple Barrett's esophagus, Barrett's esophagus with dysplasia, Barrett's esophagus with intramucosal carcinoma. Barrett's esophagus with intramucosal carcinoma. All these 3 has different management. Now coming to the esophageal tumors, I will stop here. Okay. So after this, I want to know the reason for some attitude in the student. Okay. Please be open with me. Okay. So now esophageal tumors. Now coming to the 2 tumors. Okay. 2 totally different cancer. Benign tumors are very rare. In esophagus, benign tumors are very rare. Okay. So carcinoma is very common. Okay. Now in the upper 1/3 or middle 1/3, most common is middle 1/3. Middle 1/3 squamous cell carcinoma is commonest one. Lower 1/3 adenocarcinoma is common. Because it comes from the background of Barrett esophagus. And even it is seen in tobacco use. And previous radiation therapy. So fresh fruits and vegetables scientifically proven that it gives protection. For this cancer, and the major role is P53 mutation. This P53 will be seeing in most of the tumors. P53 mutation, because it is a tumor suppressor gene. If it goes for mutation, the tumor comes. Now coming to the morphology, you can see the tumor in the lower 1/3. So distal third is affected. It can invade the gastric cardia. Okay, the cardiac part of the stomach will be affected. It can be very flat, elevated, exophytic, any different type of lesion it could be. Most commonly it is ulceroproliferative, and you will be seeing adjacent areas of Barrett esophagus, and it produces dysphagia, odinophagia means what? Painful swallowing. Dysphagia means difficulty in swallowing, and it is found during the evaluation of gastroesophageal reflex disease. Okay, so survival rate is depends upon the stage. Now coming to the squamous cell carcinoma, it is mainly due to alcohol and tobacco use, or any chronic irritation or radiation therapy can produce this, and human papilloma virus also involved in this. Okay. Now it is commonly seen in middle third of the esophagus, again it can produce ulceroproliferative lesion, and it can be well to moderately differentiated tumor. It invades the mediastinum, it goes into the mediastinum, and again it can produce dysphagia, odinophagia. Here lymph node metastasis is common, very common than the adenocarcinoma. Adenocarcinoma also lymph node metastasis happens, but here it is very common, very early it comes, and survival rate is also depends upon the stage. Okay, so this is, we end the half of the lecture. Okay, so how much time it took? Huh? Please someone tell how much time it took. 1 hour or 1.5 hours? 1 hour, huh? 1 hour 8 minutes. Okay, so we approximately 1 hour. So if I go in this pace, it is taking 1 hour. Understand? If you want to slow down, it will take 1.5 hours. Okay, so I will go in the, I can also finish this lecture in 1 hour also, complete, including stomach. Okay, so I want to know from the student what pace you want me to go. This is enough, or you want to go still slow? This pace, okay? Okay, so all the 1 hour lecture will become 2 hours. In the schedule, they will not put. How you are going to manage, I will give it to the hand of the group leader. So you likewise only all of my lectures are handled by your seniors, because actually as per credit hour, contact hour, it is 1 hour.
Yeah.
But considering, see, each education should be flexible. If I take it in some other country, I can go it in 1 hour. So for here it demands, okay, the situation demands me to go like this. So you guys have to manage. You people are adult. If you can able to manage, I will cooperate. If you guys cannot manage, because I have a lot of other works, if you irritate me, then I will go according to the schedule. Okay, so it's in your hand. Now I am going to next lecture intestine. I am not going to send handout, because I have to take everyone to the book. Okay, so when I take everyone to the book, and I have to go a little bit slower, because your first time you are going to see the book directly. Okay, so I am doing my best. So but I need cooperation from you guys. Okay, this is about the pace of the lecture, the speed of the lecture. Okay, second thing is, actually this you have to have some empathy. Empathy means you have to come to my shoe and you have to feel for it. That is empathy. Understand? So I want you all to wear my shoe, which means the teacher's shoe or the doctor's or professor's shoe, for a while when you are alone and you are taking a lecture, and students are like laughing, smiling, and going out and seeing the mobile, discussing with another girl and making other girl to laugh. It is the highest insult a student can do to a person who is sincerely taking the lecture. This is a complaint we receive from all the batches. We see in all the batches, your batch is very minimal. I'm appreciating your batch. Wallahi, it is very minimal when I compare with other batches. Okay, the best batch I taken lecture is now they are in interns. Okay, and the next batch, best batch which I am taking is that is they are in this present 6th year. So that's why 6th year pathology is also involved in 6th year. With this heavy workload, we want to give them the best. So we are going to the 6th year also. You understand?
Yeah.
Depends upon how students are treating the lecture. This extension of our work, the involvement by ourselves will come how you behave. Okay, behavior comes based on the attitude. Attitude is a belief system.
Yeah.
Understand? How far our belief system is, our ethics is Sharia. How far you believe in the etiquettes means manners, akhlaq and adab of the what prescribed by the manhaj of Salaf. So you have to follow that. So if you don't have, if I can understand, yani, like you cannot concentrate, right? Basically, why you are getting distracted? Okay, I have two sons. One son can able to concentrate very well. Another son is hyperactive child. I cannot make him to sit and learn. Okay, he is a very troublemaker in our home. Okay, so like, but he is a special, we treat him like a special child. Understand? So those who are all cannot able to concentrate, unless until you come and tell me, I cannot understand this. Because why I am telling my son I classified them is not to insult him, okay, to give more attention. If you have a serious issue in learning, come to us. If you can't concentrate, come to us. You are getting distracted, come to us. Okay, don't sit and laugh. Or you can sleep. I allow you to sleep. Or if you don't have a place, you can sleep backside. You can bring a mattress, put and sleep, no problem. And so you can keep in this corner one carpet for sleeping. Okay, so you can sleep in the back. Maybe while I am seriously thinking of what makes you to do this like this, because maybe overburden of lectures from morning 8 to evening 4. So or any kind of, I don't know what is problem, or you don't have any restroom to go, or you don't have any place to go and relax. I don't know seriously what is the issue. Okay, but don't disturb the lecture. You know, when I'm seeing such things, my flow gets, well, I see, and what is important only I'm discussing. You know, that puts lot of stress. I should not miss the major points. Understand? So that I should not allow you to carry like this. My part is to do my job perfect. Understand? I'm not working on effectiveness. I'm trying to do my job as perfect as much. Okay, so please cooperate. Okay, so because I get the same thing. Well, I was very happy when I joined this college, because you know why? Because this is Allah given me opportunity to teach 100% Muslims. Wherever I go in any part of the world, I cannot teach all 100% are Muslims. You will never, I don't know whether you realize the benefit of this country or not. Wallah, you cannot get this kind of environment anywhere in the world. Even if you go to Dubai Gulf Medical College, you will be mixed population of Muslims and non-Muslims. You will never see this. I don't know about Syria, because now Syria is not existing. So I don't know about other countries, because I heard from other senior people, Syria used to have a medical college in Arabic medium. Understand? So these are all not existing now. Understand? This is the biggest opportunity I consider, because my knowledge directly going to the Muslims. Understand? So this is a big niyama. So what I am trying to tell is, we should also behave like that, because you are representing the religion. Whatever you do, it is not like Huda is doing. It is like a Muslim doing. In front of non-Muslim's eye, it is like a Muslim behaving. If you, for example, I am having a Lara in a class. Okay, a Lara, okay, some Western female student in the class. If she is behaving, it is like she is behaving. We never say that a Christian is behaving like this. You understand? Yeah. Whenever a Muslim behaves, it is not his personal thing is getting affected. A religion is getting affected. Understand? So you all hold a responsibility of a dawa here. You know, because when non-Muslims especially, they make fun. Okay? So they make fun of you, not you actually. They make fun of the religion. Many people, because I boldly represent our religion there. So they say, like, you people say that it's all God-made law. Even in God-made law, people, students are behaving like this. This is how they make fun. So especially when you are with non-Muslim lecturers, okay, behave very, very properly, because you are representing the religion. Understand? Behave very properly as much as you can. Allah will help you, Annie. Understand? So try your best, then Allah will make the path very easy. Okay, Allah will give you energy. Understand? Allah will give you to not to get distracted. Okay, shut down the phone and throw it in your handbag. Understand? So you will not get distracted most of the times. Inshallah. Okay, so sorry for taking your time. Okay, do well, and inshallah try to buy the books.